Thank you so much, Bobby. Greatly appreciated. Hopefully you can see the slides at this point.
We can.
Perfect. So for those of you who I have not yet met, I'm Julie Gentile. I'm a psychiatrist with Wright State University, and I'm also the project director of Ohio's Telepsychiatry Project for Intellectual Disability and Ohio's Coordinating Center of Excellence. And it's an honor to be with you this morning. So we are talking about genetics and intellectual disability today, and I want to start out by just saying that this is a broad and wide-ranging topic. There are so many things that we could include under this umbrella of genetics. A lot of things that we know in this area, and some that we know less about, less information in certain areas and less research. So what I tried to do today was focus on a couple things that I find to be really useful when I study syndromes. And let's see. Trying to advance my slides here. Oh, here we go. So what I've done is I'm going to focus on a couple syndromes and a couple different ideas regarding those syndromes, and I'll explain that a little bit more along the way. So why is this significant? When I talk to medical students and psychiatric residents, as I teach every day, I mention syndromes frequently because I think it's so important for us to study this information, be aware of this information. And I read and reread about syndromes because I have found this to be really fascinating. When I first started working with patients who have co-occurring conditions, intellectual disability, mental health conditions, I thought I would know the etiology of the ID in most of the cases, and that actually has not come to pass. And I think in our clinical settings, in general, we will know the etiology or specific syndrome in approximately 1/4 to 1/3 of our patients, and usually not more than that. And so I thought the more we read about this and interface with individuals that we see in our offices, we could potentially screen for syndromes and refer individuals for chromosomal testing when appropriate. So approximately 15 or 16 years ago, I remember that we could just order chromosomal testing, and it was pretty straightforward, a straight line from point A to point B. And then as the years moved forward, I knew that we were being asked for more information. So in other words, if I wanted chromosomal testing, I had to come up with some sort of constellation of symptoms or signs from the patient, more documentation, more justification, and a specific syndrome that I was looking for example. Some of the chromosomal testing can be done for a pretty reasonable price. I think sometimes, depending on what you're ordering, it can cost upwards of $1,500 or $2,000 or even more. But we've never been denied, so that's the good news. So we have patients who have Medicare and Medicaid in both of our practices, and we've never been turned down, so that's a good thing. So, and one of my favorite books I just want to mention is Dr. Elizabeth Dykens, D-Y-K-E-N-S. Dr. Dykens is a psychologist who works in Nashville area. She's actually at Vanderbilt, and she has a publication, a book that I bought years ago, Syndromes of ID. And so I have actually read and reread this book many, many times, and just found it to be really helpful, not only because it describes the syndromes in great detail, but also because she focuses on cognitive strengths and cognitive areas of opportunity, I like to say. So in the book, she actually says cognitive strengths and cognitive weaknesses. But I like to look at this as these are vehicles and information that allow us to communicate more effectively with patients with ID, which is something I'm really interested in. So they're significant for many reasons. If I know that someone has a specific syndrome and I know the common medical conditions associated with that syndrome, then I will be more effective as a clinician in screening for those. I may have an expanded lab panel, for example. I may know that this individual will be more vulnerable to specific psychiatric disorders, and it will often influence my pharmacologic management or my prescribing practices with that individual. So when we're talking about communication, of course, we want to know those cognitive strengths and areas of opportunity. That can be incredibly helpful to us. So moving on, this is just a chart that I found. If anyone wants my references or citations, please just shoot me an email and I can get those to you. So this is a chart that I really like because it reminds us of some important things. First of all, there are genetic causes of intellectual disability. There are also lots of non-genetic and environmental causes, and we want to be cognizant of this. In particular, we see alcoholic syndrome. So we want to make sure that our message to individuals when they're pregnant is not a single drop. And there are some websites that are really helpful and have lots of information for patients to read. I know that in recent years, some individuals and some websites fell away from that not a single drop and no exposure to alcohol. And so there has been additional research added. And I think that now most of the information sources are on the same page with regard to that message. And I have a slide later on to talk more about alcohol in that interface. So when we look at genetics as a whole, from the 30,000 foot view, we know of at least 1,000 causes. And so lots and lots of syndromes, lots of information in this area, but still lots more to learn. So the most common causes, Down syndrome, the most common genetic cause. Fragile X syndrome accounts for 40% of X-linked and is the most common inherited cause. And then fetal alcohol, most common attributable cause. So together, if you add those three items together, those three syndromes, accounts for about 30%. And of course, oftentimes I have patients in my office setting that I will be assessing, and I just don't have the information. Sometimes the medical records are very clear and comprehensive, and sometimes not so much. Sometimes the medical records won't have specific information about the prenatal period and the information that we need to diagnose fetal alcohol syndrome, etc. So let's talk a little about Down syndrome. And so these are just some statistics. Sometimes you'll go on different websites. This 1 in 700 live births, I found this from this is a 2019 statistic, just an FYI. Sometimes you'll see 550, sometimes you'll see numbers up to over 700, but right in that frame, that's typically what we're talking about as far as incidence of Down syndrome. And of course, we have a couple different or multiple potential causes of Down syndrome, the trisomy 21, which is the most common. Then we also have that translocation that can happen as well. And these are some of the physical characteristics of individuals who have Down syndrome. And some of the things that are notable for me here are that there are some mid-face abnormalities and that high arched palate that can affect communication issues. That can also affect upper respiratory conditions, oral conditions, upper GI conditions. So it's really common for an individual with Down syndrome to have some medical issues that he, she, or they are dealing with. Enlarged tongue, that's really common. That can also affect speech, certainly, and I've had patients that I've provided care for who have had surgical interventions to address the enlarged tongue if they're causing problems. So, and also, you are probably very familiar with some of these other facial and other physical characteristics. These are also some common medical issues that co-occur with Down syndrome. Some of these are really painful conditions. So these are things we want to be talking to during office appointments and screening for. Certainly abscesses, that can mean someone that has an infectious disease process that's recurrent and that sort of comes and goes. And so if we have that information about the individual, then that can be really helpful. If there is behavior change, for example, that can be a form of communication to us. It can be a change in behavior or agitation, an expression that there is some physical pain or some infectious process going on. Autoimmune disorders, they're also pretty well known for, some of them can be remitting and relapsing, some of them can be sort of subtle or vague in presentation, especially up front before they really reveal themselves. So we want to be potentially doing some expanded laboratory panels to diagnose those earlier so that we can attend to those and involve the right interdisciplinary professional. Also, hypothyroidism is incredibly common in Down syndrome. There's this other interesting factoid about Down syndrome that I think we should all be aware of, and some individuals will have some temperature regulation issues. This is pretty common. So in the infant stage, infants may present with an FUO or a fever of unknown origin. And so this could be because there is a fever, and then we have to do an expanded workup, including imaging, including chest x-ray, including comprehensive lab panel, for example, to figure out what is the etiology of that fever. We want to catch things early and make interventions as soon as possible. Some individuals who are older, maybe in the transition age or adult range, they could have an absence of fever or a lower fever than someone who does not have Down syndrome. So this can be an unreliable measure of infectious process. That's really important in the context of COVID for certain, but also just in general, even pre-COVID, if someone has an infectious process and they don't have the same level of fever or the change in vital signs, then we want to be looking for other signs and symptoms to get to that diagnosis as quickly as possible. I mentioned neuroleptic malignant syndrome because that is a very, very rare but very serious side effect of some of our antipsychotic medications. And one of the prevalent signs for NMS or neuroleptic malignant syndrome is a fever. And so when we don't have the fever in an individual as one of the presenting symptoms, we want to look for other symptoms. And those may include someone who has less speech or has become mute acutely and in the context of an infectious process. And it also can be rigidity in arms and legs, so upper or lower extremities. And so the physical exam in these individuals will be incredibly important. Atlantoaxial instability is something I want to mention because this is and the prevalence is about 14% in individuals with Down syndrome. This is the C1, C2 vertebrae. So right at the base of our neck, at the top of our cervical spine, this is an instability in those two vertebrae. And so this could be a painful condition. The individual could present with whipping the head forward or leaning the head forward because that's taking pressure off of those two unstable vertebrae. They can also present in various other ways we'll talk about in just a second. This is treatable. There are interventions to help, and we want to route someone to a family practice physician, a pediatrician, an internal medicine physician. We want to get a cervical spine x-ray series, and that instability can cause problems such as, oh, I think I may be missing a slide. So it could cause problems such as changes in urination. For example, it could cause changes in proprioception, and that's where we're putting our feet one step in front of the other when we're walking or running. And so if there are balance issues, for example, then that could also be a sign of atlantoaxial instability. But that whipping the head forward or neck pain or tilting the head forward, we want to have a low index of suspicion for atlantoaxial instability. So these are the communication issues and something I'm really interested in. And so early intervention is critical. So we want to link people with resources as early as possible. There is some literature in this area that there's the ability to acquire new information slows through the developmental years. So that's something to keep track of. We want to be aware that individuals with Down syndrome may have difficulty with WH questions, with irregular past tense questions, or with embedded sentences. So they want to use sort of subject predicate kind of sentences. There could also be impaired pronunciation. That's pretty common with we talked about the palate abnormalities and sometimes with the enlarged tongue, and just cognizance of the hearing and the oral structures. That's incredibly important with Down syndrome. Let's switch now to Fragile X syndrome and cover some information in this area. So this is the most common known inherited cause of ID, and more males with ID than females. So if a female has Fragile X, then there's that second X chromosome that can influence the presentation of that. So if a female has Fragile X and they have one X chromosome that's affected and one X chromosome that's not affected, then they may have no changes at all. They could have learning disabilities. They could have ADHD. They may have mild intellectual disability. They may have borderline intellectual functioning, but it will likely look different in a female. That second X tends to be protective. It dates back to 1943, first reported by Martin and Bell, and it was initially called marker X. And you can see the stats here on this slide. So the trinucleotide, I'm sorry, the triplet nucleotide it's the repeating sequence, that CGG, on the X chromosome. So the typical X chromosome has between 6 and 50 copies of that trinucleotide. An asymptomatic carrier may have approximately 200, and affected males have approximately 100. So these are the medical conditions that we will typically tie to Fragile X syndrome. Lots of seizure disorders, mitral valve prolapse in 50% of individuals, vision problems. This could present in a range of different categories, and lots of scoliosis. Also, really common anxiety disorders and ADHD will co-occur. There's this indirect style of verbal expression in Fragile X syndrome, cluttering, and this is an example of that. How do you feel about going for a ride? And the individual with Fragile X may respond with a sentence such as, "Car's run on gas, you need oil too." So they're combining bits of information from different topic areas in response to that question. Some of the other communication patterns that are really common in Fragile X: avoidance of eye contact. I have had many individuals on my caseload with Fragile X syndrome that I've seen in my office setting, and usually I would prep my office when I was seeing them in person, face to face. I would typically prep my office and put chairs at different angles. If you put chairs at 45-degree angles, individuals will typically be less anxious. Some of the individuals will avoid eye contact by wearing sunglasses indoors. Some will wear a ball cap and sort of pull the bill of the ball cap down so that there's less eye contact, or it's easier for them to avoid eye contact. And the Fragile X handshake is really interesting because the individual, most individuals with Fragile X, they want to connect, they want to talk to you or have a conversation, but there's a lot of social anxiety typically. And not in every case, certainly everyone's an individual, but the Fragile X handshake is when an individual will stand at a 45-degree angle and they will look down or look away, but extend their hand to shake your hand. And then after you have looked away, once you have broken eye contact, then they will look at your face. And that's really typical, and that's called the Fragile X handshake. So these are some other cognitive strengths of Fragile X. The verbal skills, typically really well developed. Long-term memory is incredibly well developed. Also receptive and expressive vocabularies. And there's automatic phrases. This is something that's been tied to Fragile X. And I had a patient one time with an automatic phrase. He used to say, "I'm going to punch you in the nose." He used to say, "I'm going to punch you in the nose," when he would come into my office for appointments. And sometimes when he said this out in the community, it didn't work so well and it wasn't really adaptive. And so an automatic phrase is a phrase that an individual with Fragile X will create and come up with and use as a pattern. So if you pose a question to an individual and they're not quite sure how to answer that question or how to respond, then they'll go to their automatic phrase. And this is really adaptive. And this is one of the things I found really fascinating, that often the automatic phrase is in the form of a question. So that not only is it a response, it's a go-to response that they're comfortable with, but it's also, it lobs the conversation back to another individual. And it might be you and it might be a familiar other. So if I had a patient in my office and there was a DSP or an SSA or a family member with that patient, then the automatic phrase would often be, "What do you think, Mom?" Or "What do you think, Danny?" So it lobs the conversation back. It's an automatic phrase, and you're also including oftentimes a familiar other. So completely adaptive and really interesting. So with the patient, just to sort of close that loop. So the patient whose automatic phrase was, "I'm going to punch you in the nose," we talked to him about that, and we got together as a team, and then we included the patient in those conversations. But we were explaining to him that sometimes when you say that, it could make me feel like you're mad at me, or it can make me feel like maybe I said something wrong that you didn't like. And so we came up with a different automatic phrase and we posed it to him as an option. And so we posed to him that he could communicate to people that maybe that person needs a pep talk. And so he started saying, that person needs a pep talk. Bobby needs a pep talk. And he started saying that, and that was more adaptive in various environments, out in the community, for example, at day program, at his supported residential setting. And so that's something that you can talk to the patient about and explain to them how it's being potentially interpreted by other people, but make it still functional and significant and important. So this is just a slide that connects some other syndromes to some specific mental health issues and or some behavioral presentations that I thought was sort of important. And then I'm going to close up because I know I've run over time a little bit here, but what I've done is I've got some final thoughts for you, but I've also included in this slide deck, I've got 5 or 6 more slides that just give you a slide full of information of some of the other very common syndromes that we might come across in clinical practice. And so we want to educate ourselves through cognitive knowledge. So I think reading and rereading and studying and teaching, I think those are all important. Also, just as many patients as you can see and interface with, I think that helps. So the experiential knowledge is incredibly important as well. And so I think this leads to better interview and better relationships, therapeutic alliances, better information. And we want to make sure we remember that there's no cookbook or recipe, that each individual is just that, an individual. And there are some common characteristics that may help inform our decision-making and our prescribing and screening for medical illnesses and focusing on those cognitive strengths, which I have found to be incredibly helpful in my practice. But these are contextually and individually based. So that's all I have for you today. Thank you so much for your time and attention. It's been an honor being with you this morning.